Hello, this is Abdallah Abu Talib. I'm working for WHO. My daily living is healthcare reforming policy. Thank you to be with me, and I will be with you in this workshop about developing antibiotic policy, what the challenges and the opportunities, and what should we do for our countries. Let's talk about the story started with. Antibiotic exposure is the single most important risk for seed difficult infections. Exposure to antibiotics increase the risk of C. difficult infection by at least threefold for at least 3 months. Up to 85% of patients with C. difficulties infection have antibiotic exposure to the 20th day before infection. Antibiotics accounts for nearly 1 to 5 drugs related to adverse events. 1004 more than 1040 ER visits here due to the adverse effect of antibiotics. Admission required for 6.1 for adverse event. So this is represented as a very important problems, and I will show you also another slide. This is what is going on for time series of monthly antibiotic use over 10 years with 5 segments demarcated by vertical lines, and also calendar plot showing trends and seasonal pattern of overall antibiotics use. So we have a problem, a serious problem. So we should know about what is the core elements of hospital antibiotic policy. I'm trying to give you some examples. For any policy, we're talking about three elements, awareness, governance, evidence, and practice. I'm showing you now policy review. This is the 4 elements for any antibiotic policy, and I will try also to give you some examples for this. This is an example for awareness for AMR. AMR, what's one of the major anti-infectious diseases happens in Europe. We work it in 2 programs. One of them is education, and the other is evidence and awareness. In your country, when you are doing something, you should know what is your needs for your payers, what is the stakeholders for policy mapping in your country, to know what is the exact policy you should use. If we go previously to this slide, especially for this elements, look for awareness, governance, evidence, and practice, and modify these elements based on your country, your needs, your skills. And I will show you now some tips for how to make core for antibiotic policy. What is the rationale and goals for antimicrobial stewardship programs? One of them, understand the core elements of effective antimicrobial stewardship programs. Also, learn how smaller hospitals can improve antibiotic prescribing. This is one of the goals for CDC. And now we are talking about antibiotic use drivers resistance. For an individual, getting antibiotic increase a patient's chance for become colonized or infected with a resistant organism. Increasing use of antibiotics in healthcare settings increase the prevalence of resistant bacteria in hospitals. And this is how the infection and resistance happens, starting from lots of grams, a few are drug resistance. Antibiotics kill bacteria causing the illness, as well as good bacteria protecting the body from infectious and from infection. The drug resistance bacteria are now allowed to grow and take over. Some bacteria give their drug resistance to other bacteria, causing more problem. We are facing a very big problem. Now let's lead to the policy. When we are talking about policy, strategies, multidisciplinary and facility-specific efforts to optimize antimicrobial prescribing. This multidisciplinary should include right drug with the right dose, with the right duration, and recognized when not needed. Again, core elements of antimicrobial policy: landscape commitment, leadership commitment, accountability, drug experts, action, tracking. This is the 4 or 5 elements, and I will try to explain one of these elements on the next slides to make you some advices and also reporting. And without education, all the previous elements will not be used or will not be useful or will not be effective. So education is one of the cornerstones for representing and if you want to have an effective and efficient policy, you should make a good education for a good leaders based on their accountability and based on their expertise, and then you will have a good actions by good tracking with an effective reporting. This is the effective plan for antibiotic policy. Now I will start with leadership commitment. Leadership support for effort to improve and monitor antibiotic prescribing. Assuring that involved staff has time, authority, and accountability. If the staff doesn't have the authority, he will not have the efficient policy. If the staff doesn't have time, he will have mistakes. And if he doesn't be an accountable person, you will not have an efficient policy. Funding can augment efforts and also staff time to accomplish goals, training for staff. This is the elements for leadership commitment. Without data, you will not have nothing. Data means IT. If you don't have data, you will not have reporting. You will not have efficient reporting process. So IT is the core of data management. Now, accountability. For accountability, program leader identify single leader who will be responsible for program outcomes. Physicians and or pharmacists have been highly effective in this role. Some key supporters: clinicians group, infection perfectionists, quality improvement staff, laboratory staff, nurses. All these elements are supporters. Again, for the policy, you should have the language to talk with these groups, every group and every element with the language that they can understand. What about drug experts? What do you think about drug experts? Identify pharmacists to be involved with formal training in infectious disease and or antibiotics stewardship is beneficial. Pharmacists can assist in identifying areas for improvement and monitoring use. And for the program function, develop guidelines, policies, and protocols that support optimal prescribing. Again, for the policies and guidelines, you should taking into consideration education, training, evidence, experts. And also you should make prioritization for your effort, specific condition, particular units or prescriber groups, specific antimicrobial drugs. And always educate how to monitor and report everything. And here is some infection and syndrome specific intervention: community acquired pneumonia, urinary tract infection, skin and soft tissue infections, tailoring treatment to culture result, Clostridium difficult infection. This is one of the difficult infection that might be have facing any person working in this medical staff. Again, what about guidelines? Facility specific guidelines based on national guidelines, local suspiciability. Select and review charts. What is the current practice? What can we improve upon? Again, for your guidelines, you should into consideration the practice needs, the practice analysis, the quality modules, and the language which be guidelines which should be written, and also treatment algorithm and the journey for the guidelines. Without involvement of the prescriber, you will not have an efficient guideline. Develop order sets that incorporate guidelines. And what about actions, interventions? Guidelines, policies, and protocols alone will probably not change practice. So, what will change the practice? Active interventions are most effective: prescriptive audit, formulary restrictions, and prioritization, antibiotic timeout. This will make the intervention effective. And how we can achieve this? I think we need a prospective audit. A prospective audit and physician or pharmacist review orders and interventions with modification of orders and feedback to prescribers. Results in improved use, decreases cost and cavities, time and labor intensive. Many settings don't have capacity, previously may not be receptive. And I will show you now how a prioritization can affect. For the use of antibiotics, you can see the decline area. This means we have a good policy and good interventions and good audit policy and prioritization policy. And based on this prioritization, we will have a concept called pharmacy-driven interventions. It is automatic changes from intervention to oral antibiotic therapy. Automatic alerts in situations when therapy might be unnecessary, duplicative. Dose adjustment, optimization, time sensitive, automatic stop orders. This is one of the main concepts for primary driven intervention. And I will give you also some additional core elements. Tracking. If you have a good tracking and monitoring of antibiotic prescribing and resistant pattern. Reporting, regular reporting information on antibiotics use and resistance to doctors, nurses, and relevant staff. And this is a good tip for you. You will evaluate the outcome and monitoring the process. So you should have both tracking and reporting. And when your process in tracking and reporting is easy and accessible, you will achieve the goals with efficient resources, with efficient budget, with an easy way. How you can do this? By education. Again, education clinicians about resistance and optimal prescribing. Education is the first step for awareness campaigns. What is antimicrobial stewardship? Successful example, I will give you now. And now this is the outcome. Number of intervention increased from 2 to 7 per week. Streamlining was most common intervention. 44% before program and 96% after program began. Clostridium difficulties infection decreased from 5.5 to 1.6, which are magnificent and significant decreasing. Antimicrobial purchase cost, and also cost is reported for any hospital by this number. What happened next? We made a moving stewardship to the front lines. Every participant should embrace the responsibility to optimize antibiotic use. Starting point, identify specific intervention that people can do improve antibiotic use. This is the core elements for any antibiotic policy. Again, successful example, but in this time it is not a successful example for me. You should take into consideration these 4 elements: awareness, governance, evidence, practice. You should know this is the core elements and implement based on your needs. It will be a pleasure to have this presentation for you. Thank you and see you again.